Okay. So, on behalf of Department of Neurology, I welcome you all to today's presentation, and this is from Unit 3. And Dr. Awad will lead the presentation. I invite Dr.
Thank you, sir. And I will not take much time. And we are presenting a very interesting case, which we can think, I just probably tell it's an autoimmune condition of brain. And it can present such a catastrophic way and fulminant way and can respond the way you will see in this case discussion. And I welcome Dr. Farsana, Senior Resident, Department of Neurology, who will elucidate this case. Thank you.
Thank you, Awad sir. Respected faculty and my dear colleagues, case is brain on fire through thick and thin. So we had a patient, Miss A. She was a 17-year-old girl. She presented with seizures for 11 days and behavioral abnormalities for 8 days. So in day 1, she started having fever. She started having headache, which was bilateral frontal type of headache, which was throbbing in character. And on day 3, she started having aggressive behavior with some water restlessness and one episode of doubtful seizure. This happened when she was alone in home with their maid. And on day 3, she started having some compulsions in her behavior. Especially, she was like taking bath multiple times. And another episode of seizure, which was also an unknown onset tonic-clonic seizure, which was a very brief duration. And for that complaint, she was taken to a nearby hospital from where levetiracetam was added and EEG was done on that particular day, which was normal. And on day 5, she again started having seizures, and this was also a brief seizure. And for which they had got a MRI done from another outside hospital, and that MRI was normal. She was again taken back to home. On day 6, when she started having fever and with increased headache and seizures, she was admitted. And this fever lasted for 2 days. And during that admission, they got evaluated with their CSF examination, which was showing 90 cells with 99% lymphocytes. And protein was raised 56 and sugar was 66 with a corresponding RBS of 120. And her total lymphocyte count was also 18,000. But her infectious workup from the blood and also the CSF infectious panel was negative. And at that particular point of time, they had done a serum and CSF autoimmune and paraneoplastic encephalitis panel, which came out to be negative. And during these days, she started having her labile mood, aggression, anger outburst, and all these irrelevant talks. And after this lumbar puncture report, they have started her on injection acyclovir, ceftriaxone, artesunate, and dexamethasone, and it was given for 6 days. And on day 8, she started having auditory and visual hallucination, and she was in a psychosis when she presented to us. And on day 10 of her beginning of her illness, she reached AIIMS emergency at a night. And from there, because of this psychiatric symptoms, we have changed this, because of her aggression and all, we have changed this levetiracetam to Briva. And this was the day 10 of illness, where patient was having this aggression, hallucinations, and she was having this repetitive sensations. So she was having this perioral dystonic movements, and also she was having this repetitive behavior and stereotypical movements, and also vocalization. And for which we have added taclitipin, clonazepam, and we were struggling to manage her, and we managed her with lorazepam and haloperidol stat doses also. And she was having this palilalia and some episodes of left focal motor sections. But there was no history of any weakness of upper limbs or lower limbs, and no history of any sensory symptoms, and no history of any joint pain, rashes, and any history of loss of weight or loss of appetite or jaundice. And personal history, she was a vegetarian by diet, and bowel and bladder habits were normal. No history of any substance abuse. Family history was not significant. On examination, her general examination findings was not contributory. There was no KF ring, and her vital examination, apart from an increased heart rate, it was 110 per minute, and blood pressure was normal at presentation, and the other system examinations were also within the normal limits. And a neurological examination, patient was agitated, and GCS was E4, V5, M6, and higher mental function could not be assessed. And cranial nerve examination was normal, and motor system, sensory, cerebellum, sensory and cerebellum we could not assess. Motor system examination was normal, and in extrapyramidal system, she was having this perioral dystonias, mask-like facies, and dystonic posturing, multifocal dystonia of the limbs. So we were dealing with a neurobehavioral syndrome, which was acute in onset with seizures and movement disorders. So analyzing the symptoms, this neuropsychiatric symptoms she was having features of aggression with impulsivity and reactivity and disorder of volition and self-control. That is, she was having these compulsions, and motor restlessness, which was manifesting as this restlessness and fidgeting and affective states with this irritability, anxiety, and agitation, and abnormal percepts, which was hallucinations. And in terms of seizures, she was having these unknown onset tonic-clonic seizures and left focal motor seizures. And in movement disorder, she was having these vocal stereotypies, which was this repetitive coordinated movements, and also dystonia she was having. And so, based on these clinical findings, we have kept the clinical differential diagnosis of autoimmune encephalitis as the first possibility, where in a young female we will think about NMDA receptor encephalitis. And also we have kept the possibility of CNS infections like HSV1, 2, Treponema pallidum, and systemic autoimmune disorders like SLE, and some neurometabolic disorders which can have the first presentation like Niemann-Pick C, Neuro-Wilson, and Gaucher 3, and endocrinological disorders which can present as the first manifestation: thyrotoxicosis, hypothyroidism, hyperparathyroidism. So, based on this, our possibilities, we started investigating our patient, where the routine investigations, apart from the leukocytosis, which was 16,200 TLC, the other investigations were within normal limits. Her calcium and phosphorus was normal. And we did her viral markers and serum VDRL, which was negative. And we proceeded with a LP because she already had an imaging which was done from outside and reported as normal. And in LP cells, she had 30 cells, and which was 85% mononuclear cells, and protein was 43, which was normal, and CSF sugar was also normal. And her infectious screen from CSF was negative. And her thyroid profile and anti-TPO was also within normal limits. And we have also screened ANA, ENA, ANCA, which was also normal. So we have sent a serum autoimmune encephalitis panel repeat, which was showing occasional positive cells in serum, and CSF autoimmune encephalitis panel showed strongly positive NMDA, and serum paraneoplastic panel was negative. And we have thoroughly evaluated her for teratomas by ultrasound pelvis, PET CT, and MRI pelvis, which was not showing any teratoma. So this is this indirect immunofluorescence was the technique which was used for the detection of NMDA in CSF, which was showing the strong positivity. So to discuss the neuroradiology finding, I am welcoming Dr. Suraj from Neuroradiology Department.
Thank you, ma'am. On MRI, T1 weighted image shows bilaterally symmetrical hypointensity on medial temporal lobes, and T2 flare hyperintensity on same site, that is bilateral medial temporal lobes. However, typically there is no post-contrast enhancement and no any abnormal diffusion restriction was seen. These findings are mainly consistent with autoimmune encephalitis.
Good afternoon, everyone. The patient underwent equating FDC PET-CT on 6 September 2024. These are the PET-CT images of brain showing hypometabolism in the area of bilateral, parietal, and occipital region. The 3D Z-score imaging also constantly highly negative Z-score in the region of bilateral, occipital, and parietal regions. Then to rule out paraneoplastic etiology, the patient underwent whole body PET-CT image, the maximum intensity projection image showing no abnormal accumulation in the body. Then the Argent slices showing benign cystic anemia. So the overall scan findings are consistent with autoimmune encephalitis pattern.
So on admission, the first day itself, we have started her on IVIG, and she had this persistent perioral movements. And on day 2, we have after doing the CSF, we have started her on injection middle prednisolone pulse therapy, and this perioral dyskinesias and aggressive behavior was continuing. And she was having this vocalizations and many extracriminal manifestations. And also she had on day 3 generalized tonic-clonic seizures, and also she had focal seizures, and her ASMs were optimized. And on day 4 she had catatonia, due to which she was electively intubated. So according to the DSM-5 criteria for catatonia, our patient was having this stupor, waxy flexibility, agitation, mutism, posturing, and stereotypies. So 3 or more of these 12 psychomotor features can fit into the diagnostic criteria for catatonia. And throughout the disease course, even after the first line agents and rescue therapy, she was having this dystonic posturing, and also she was having dysautonomia, which was there persistently throughout her course. So she was actually having paroxysmal sympathetic hyperactivity. According to the definition, we can see the restlessness and agitation and dystonia in a patient with tachycardia, hypertension, tachypnea, and fever. So our patient also had some storming symptoms, and so we have managed her on based on those guidelines for paroxysmal sympathetic hyperactivity, and we have given her the anti-epileptic agents were also optimized based on this, and we have added metoprolol for her, and there was no benefit in paroxysmal sympathetic hyperactivity and dystonia even after addition of the midazolam, even after addition of metoprolol. So dysautonomia, for dysautonomia, we have taken a cardiology consultation also, and we were managing with stat doses of metoprolol, and 2D echo was also done, which was normal. And as we have to shift to the second line agent, we were doing pre-rituximab workup simultaneously, for which hepatitis C core antibody was also positive. So the core antibody was 4.36, and hepatitis B viral quantitative RNA DNA level was not detected, for which we had opted for a gastroenterology clearance, and they have advised us to add tenofovir. I welcome Dr. Shubham to discuss regarding the aspects of regarding gastroenterology aspects.
Good afternoon, everyone. So, hepatitis B carries a significant risk of reactivation following immunosuppression. So, the first step in such a scenario is to assess the risk of reactivation depending upon the immunosuppressant in contention. Drugs such as rituximab carry a high risk of reactivation to the tune of more than 10%. In such a scenario, the next step is to assess 3 markers, that is hepatitis B surface antigen, hepatitis B core antibody total, which is only qualitative, not quantitative, and HPV DNA. The latest recent guidelines suggest that if the patient is HBsAg negative and total core antibody positive, and if the patient is deemed to be studied on high risk immunotherapy category, rituximab, for example, these patients must be studied prophylaxis, which would either be PAP or entecavir. The prophylaxis must be started at least 1 week prior to immunosuppression, and the prophylaxis must be continued for at least 18 months after stopping the immunosuppression.
So we have added tenofovir alafenamide for our patient, and she was having this continuously disabling dystonia, for which we have added all the medical therapy. She was on clonazepam and tetrabenazine, trihexyphenidyl, and we were also giving intermittent bolus doses of phenytoin and midazolam, and also mostly she was having the dystonic posturing in her left hand, and sometimes we used to see bilateral hands going for a dystonic posturing. Some focal seizures also used to happen intermittently, where we were used to detect by seeing the continuous EEG records. So for paroxysmal sympathetic hyperactivity, we added gabapentin also for the management. So we took a infectious disease consult also give injection rituximab, the next dose, because patient was having this ET cultures which was showing Pseudomonas and Klebsiella. And we have managed that with broad spectrum IV antibiotics. But persistently, even after first dose of rituximab, also patient was having this tonic posturing and dysautonomia, which got eventually settled. So this was the kind of dystonic posturing which patient was having, where we found it very difficult to manage the patient. And after the second dose of rituximab, which was given after sorting our infectious disease consultation, we after 1 week we saw the improvement in patient, and eventually she improved after the second dose of rituximab. So challenges we faced in this case were the negative antibody status in the serum and CSF on the initial testing, and managing the unmanageable symptoms like neuropsychiatric symptoms, status epilepticus, and the complex movement disorders and this dysautonomia. And is there any entity called fulminant NMDA receptor encephalitis? It's a new paradigm in autoimmune neurology. I'll be explaining about it, and the timely initiation of immunotherapy to outsmart the immune system, and failure of first line therapy to evade the immune mediated attack. So we have to escalate to our second line agent or to a third line agent if the patient is not responding. And tackling the twin threats that we usually encounter in our common clinical practice, this hospital acquired infections and underlying chronic infections, which may have the risk to play after immunotherapy. So this is the follow-up video for our patient after 2 months follow-up. So now she is on monthly IVIG doses. You can see her walking through the garden with her mother, and she is on monthly IVIG doses, 1 gram per kilogram. Now we are giving, and also she got injection 2 doses of rituximab. She will be after assessing, she will be also on the maintenance doses of rituximab. So usually the classically defined the 5 sequential stages of NMDA are the prodromal states, psychosis and seizure states, unresponsiveness or catatonia, and hyperkinetic movement disorders, and the gradual recovery stage. In majority of the patients, we tend to see a subacute onset of psychiatric symptoms, seizures and movement disorders, followed by dysautonomy and altered sensorium, usually within 3 weeks of symptom onset. Fulminant presentation can have the overlapping symptom complex and some atypical imaging findings also. As in our case, it was a normal brain imaging at the first place initially. And small subset of patients may exhibit this fulminant cause and demonstrate resistance to initial immunotherapeutic interventions, as in our case. In such instances, the most appropriate course of action remains actually a matter of debate. In a recent study by Lee W. and colleagues, they have started the upfront immunosuppression with, if there is a teratoma, we have to actively search for a teratoma, and we should go for a teratoma removal, pulse steroids, IVIG, or Plex. These are the rescue therapies with second line agents like rituximab and sometimes maybe tocilizumab within a span of 1 month. They have studied this, and this have yielded superior efficacy compared to the delayed or partial application. So we tend to lose many of our patients within 1 week of presentation itself, and we have such experiences in our routine neurology clinical practice. So, how to differentiate between infectious encephalitis and autoimmune encephalitis? This is an age-old discussion, but there are no much points of differentiation. The only thing is that like both can have fever also at the presentation. Even in autoimmune encephalitis can have fever, and seizures are common in both. But this type of movement disorders, maybe the psychosis, the neuropsychiatric symptoms may be more prominent in autoimmune encephalitis, and this complex movement disorder phenotypes like perioral dyskinesias and dystonias and also psychosis will be more common in autoimmune encephalitis, and most common imaging finding will be a normal MRI for autoimmune encephalitis, and the CSF picture may resemble in both of these conditions. So antibody negativity. So there can be antibody negativity. There are case reports and also a retrospective study which in this retrospective study they have studied about 250 patients where only 211 patients had antibody positivity, but still antibody negativity was also there in their subgroup. So initial antibody positivity should not halt our clinical management, we should have a high index of clinical suspicion, and dystonia management, which was a very severe and disabling symptom in our case. So literature also says that they have used botulinum toxin for such disabling focal dystonias and all, and especially for a perioral dyskinesia, which was very refractory. And one case report is there, which was published in PRD for deep brain stimulation in status dystonicus in NMDA receptor encephalitis. So the clinical presentation of fulmin and NMDA receptor encephalitis is characterized by the constellation of these neuropsychiatric symptoms, seizures and movement disorders. So as we practice in our stroke neurology, time is brain is also applicable to autoimmune neurology. So there is a critical role for early second line immunotherapy to improve the outcomes in such cases, and we have to overcome the hurdles that we routinely encounter in our clinical practice, the challenges in administering immunotherapy. Thank you.
Thank you, Dr. Prasanna. And I will just want to say that this autoimmune encephalitis, we should have very high suspicion, index of suspicion, and we should be aggressive in immunotherapy. In this case, I brought it because initially outside it, she was treated as viral encephalitis, and then it was suspicion of a adverse effect of levetiracetam, so that because there is worsening of her neuropsychiatric symptoms. But still, when she evolved into the complex movement disorders, then dysautonomia and young female and unresponsive to therapy, then we had a high suspicion and she was initiated on this treatment. She was almost in a very catastrophic state, which lasted for almost 4 weeks. And another thing which we learned is if the patient has responded to first line by steroids, IVIG, there is also option of plasma exchange. We did not give because of the severe autonomic dysfunction. So at least 4 weeks we have to at least see 3 to 4 weeks for these drugs to show any effect. Otherwise, we should start on the patients on second line. The options are rituximab, tocilizumab, and there are more drugs. And she has responded really well, and you could see the lady in white dress. She was walking with all comprehension, and her tracheostomy has been removed. We had another challenge in her maintenance immunotherapy. We have continued, given her induction rituximab. At 6 months, we will try to see what is her level of immunosuppression. But in the meantime, we have also given her monthly course of IVIG, which is 1 gram per kg body weight. Although I don't have a very well designed randomized control trial to support this of a monthly dose and maintenance, but at least we will keep her a good immunosuppressed state for 1 year and keep the tumor screening every 6 monthly for at least 2 years to show. And as far as outcomes, they respond very well. One of the Leo score, which shows that she will improve up to 95% in 1 year. But there are risk of recurrences, deaths, which are almost 10 to 15% if untreated. Thank you. Any questions? Any comments? Okay. Any comments? Dr.
I had a question for the next colleagues. So the hepatitis B co-transmission infertility, how given is this with the population? Because we see it very commonly in most of our activities. We had a doubt whether because most of the patients will be widely active. The number of them after IVIG could it be a false positive?
I'd like to answer the second question. So yes, if you send the sample after IVIG, it can be a false positive. You have to reconfirm it after 4 weeks. That is first. Second is how common it is. We don't have Indian data. Western literature states it is as common. But what we need to realize is that core antibodies, total core antibodies must be sent. We should not just stop with HBsAg negativity and plan these patients for a high level expression such as rituximab. To take home point. Second is the titers may not be necessary. Only the qualitative positivity is enough to start the drug. and we don't need to wait for maybe like 4 weeks of the to act, and then the induction. That's not the case. You can start straight away even within 1 week.
So I think important learning point was our resident food that we should send sample before initially actually.
So okay, then we close from neurology side, or if there is any.
I, I totally agree, sir. We should do this test in our hospital. Totally. And we have same problem as well. We have to same.
So, human diagnostic panel for seronegative autoimmune inflammation, because here you are lucky about the antibody positive. So, is there anyone doing an environmental cell culture on which the KSL can be washed on and then do a sample, even non-specific antibody? Because it depends on the technical has been picked up by the immune cell or antigen. So there have been many antidotes. Innate receptor itself is a huge receptor. And there are many other receptors that could become a source of autoimmune. So in those cases where there is a negative screen, is there a mechanism by which it can be diagnosed within the department or the institute?
Yeah, this case it happened in the same way. Initially screening, she came with a negative NMDA receptor antibody, but in our situation we don't do it. So we are usually collaborating with NIMHANS value, and they would test all these, and then from there we got this positivity of. But there is another hypothesis because she also had initial fever, and so sometimes there is reactivation following a viral encephalitis. But anyway, that is one possibility. But definitely we got it from the NIMHANS value.
Very it's always been yeah, but you miss sometimes you know see
Yeah.
the same service. So whatever services there are three programs in this three formatted that is what standard service. But serum and CSR both should be sent in our patient system. And then you look at the solution for the so let's say you have to see for negative AI. We do have people everything. So don't wait for an antibody.
So with this we conclude from Department of Neurology. Thank you.